A start.
23-year-old Mohammed, born on 17th May 1949, he lives in Trishur. He is retired. He studied up till grade 4th standard. Presented with history of fever and cough, 1 month duration, and swelling of both lower limbs of 2 weeks duration. History of present illness. Patient was doing well till 1 month back. Since 24th of August, patient complains of high-grade fever with associated chills and lighter. Fever spikes more during evening hours with associated involuntary micturition and disorientation at the time of fever spike. He also complains of cough without any expectoration since the past 1 month. Since the past 2 weeks, he also complains of swelling of both lower limbs involving the ankle and the foot, gradually progressing, more profound during the evening hours and subsiding in the morning. Uh, there is also associated history of loss of appetite and loss of weight in the past 1 month. No history of any abnormal pulmonary symptom, palpitation, rash associated with fever, rhinitis, breathlessness, swelling of other regions of the body, additional variation in cough, myalgia, or any history of bleeding manifestation. Patient was taken to one-star hospital on 20th September and he started on medication there. But however, the fever persisted with temperature recordings of nearly 100 degrees Fahrenheit and fever spikes were present without any diurnal variation. He was then referred from there to our hospital for further workup on 24th September 2020. Review of systems. Respiratory system. He gives a history of dry cough without an expectoration. Uh, Other systems, nothing contributory. Past history. History of fever and cough. 2 episodes since the past 3 months, which subsided on medication with a 20-day fever-free interval in between the 2 episodes. No hospital admission was required for the same, however, and it was based on treatment on AP management. He's known case of rheumatoid arthritis on treatment since 2008. No history of any joint abnormalities presently or any joint pain. Uh, he's known case of type 2 diabetes in the past 10 years on medication. No history of any tingling or numbness of lower limbs, coughing of urine, any visual problems, bowel or bladder disturbances. He was recently diagnosed to have systemic hypertension 7 months back and is on medication for the same. Patient was diagnosed to have Parkinson's disease 4 months back, following evaluation for slowing slowness of movement, stoop posture, and gait, which was and for questioning gait, and is on medication for the same. No history of any pulmonary tuberculosis, occupational exposure to allergens. Family history. No history of similar episodes in the family. Um, his father passed away due to CVA, and there is no history of similar illness in the family, other members of the family. Mm, Personal history: sleep is normal. He has non-vegetarian diet, and appetite has been is reduced since the past 1 month. Bowel and bladder habits are regular. He is an ex-smoker, stopped 26 years back, and past years is 20. Non-alcoholic, no history of other addictions. Treatment history: he's on treatment for type 2 diabetes mellitus, taking tablet metlaside 50 mg in the morning for uh, uh, hypertension. He takes lisinopril 40 mg in the morning. Parkinson's disease, levodopa carbidopa combination, and donepezil. He's on methotrexate 7.5 mg, which he has on Sundays for rheumatoid arthritis, and tab Allright, which he takes on Saturday and Monday. He's also on tab leflunomide. And for BPH, for benign prostatic hypertrophy, he's also on medication. There's tamsulosinate finasteride combination. Uh, there's a history of hospital admission 2 years back due to the same history, due to fever and corrected cough. Uh, and it was managed, and he had to be admitted for nearly 2 weeks. Uh, dietary history. At 8 o'clock in the morning, he has 2 dosas or either upma. He follows a diabetic diet. At 11 a.m., he has 1 glass, nearly 250 ml of with our salutaries. At 1 p.m., we have one glass of black tea without sugar, along with 2 biscuits, and at 8 p.m., two chapatis along with curry. Uh, Activities of daily living. He was able to do matters pertaining to himself by his own. Since the past 1 month, patient requires support for doing his activities. On general examination,
Wait. From the history, what do you make out?
this is he's got a respiratory tract infection.
Infection. Why do you conclude like that?
Infection. Because there is fever.
So what are the chronic disease of respiratory system you know of? Other than infection? Other than infections?
Malignancies.
Malignancy, can they have fever?
No, lymphoma presents with fever.
Yes, malignant, sometimes they can have fever, yes. What about connective tissue diseases? Can they have fever?
Connective tissue diseases, yes, they can have fever.
They can have fever.
Yes.
Okay. Can drugs produce fever?
Yes, sir, can produce fever.
Drugs can produce fever. So fever can be there by non-infective disease also. Okay. What about sarcoidosis? Can we have fever?
Sarcoidosis, no, usually presents with cough and breathlessness.
Yes, PEO can be a presentation of sarcoidosis. Comes as a differential diagnosis for PEO. So that can also be part of the story. Okay. Infection, which infection comes to your mind? Which infection comes to your mind?
Tuberculosis.
Tuberculosis tops the list. Yes, other infections? Other infections?
Any? No.
Yes, you must think of
Any?
Pneumocystis carinii infection, which can also produce diffuse shadowing in the lungs, and you can have.
Yes, sir.
Okay, so that is one possibility. So can okay, what did you say?
Mycoplasma.
Mycoplasma can have fever. Yes, that's infection. Yes, mycoplasma can have fever. Yes, that's infection. Yes. Hypersensitive pneumonias can be with fever.
Yes, sir.
Lymphangitis carcinomatosis can have fever. Yes, fever is there. This particular patient who is a hypertensive, any other possibility comes to your mind when there is a dry cough? ACE inhibitor can produce dry cough. When somebody presents dry cough, what other possibility that comes to your mind? Dry cough. Interstitial lung disease, very good. Anything else? Cough variant asthma should never be forgotten. Gastroesophageal reflux disease. Okay, these are the things that comes to your mind when somebody has got dry cough. But here not only dry cough, they got fever also as an important point. What is the usual presentation of interstitial lung disease? Fever or cough?
With cough, progressive exertion dyspnea.
Yes, they come with dyspnea, not cough. Yes. Dyspnea is the most important complaint for them. Okay. So from the history, what do you make out of the diagnosis in this case?
Pyrexia of unknown origin.
Can you say it's a case of rheumatoid arthritis complicated by interstitial lung disease?
Yes, sir.
So that's one possibility.
Yes, sir.
But interstitial lung disease per se doesn't produce fever. So some complication of interstitial lung disease has taken place in the form of infection or something else is taking place. Otherwise you cannot have fever. Morning, more in the evening. When is it?
More in the evening hours.
Yes, what does it mean to you? So dependent edema, gravitous edema. So common cause of gravitous edema are hypertonia, heart failure. Is there a chance that this patient is having heart failure?
Yes, possibility is there.
Possibility is there.
Right heart
Right heart failure. That's right.
failure.
He can be having a right heart failure. That's also possible. Okay.
Yes, sir.
Hypoproteinemia may be there if he is not eating well. That's also
Okay,
possible.
sir.
Right. Then
Okay, sir.
general examination.
On general examination, patient is comfortable bed in sitting position. His thin built, adequately nourished. Mid-upper wasting present. No temporal hollowing.
No,
Uh,
you are looking at the wasting of the skin fat pad, mid
Fat
arm
pad, yes.
fat pad, not the muscle. Okay.
Okay, sir.
Yes. Is he on an oxygen?
No, sir.
Is a nebulizer kept bedside?
There was no nebulizer kept bedside, sir.
Okay. Okay. Yes. Yes. Carry on.
Uh, uh, on exam, father
Body
present,
mass
bilateral fitting
index.
field led. Sir?
Body mass index.
Sir, body mass index could not be calculated,
Calculate.
sir.
Okay. Fine.
He was.
Okay. Right.
Yes.
Mm.
Pallor present, bilateral fitting field edema present, no aqueous cyanosis, clubbing,
No cyanosis. Do you
lymphatic.
expect cyanosis in this
No, sir.
case?
Yes, we expect
Why?
cyanosis in this
Why?
case because of hypoxemia, uh, chronic disease,
One cause for
sorry,
cyanosis is. Sorry. Yes.
hypercarbia. Hypercarbia
Yes.
to,
This patient can have respiratory failure. He can have cyanosis. We expect it. But you already said he is anemic. Can anemia and cyanosis coexist together?
yes,
Is it possible?
mm,
It's not compatible with life.
like,
It is not compatible
yes,
with
sir.
life. So cyanosis and clubbing will not go together. Yes.
Okay, sir.
Is he clubbed?
There is no clubbing, sir.
No clubbing.
No
Is
clubbing.
it expected?
It is expected.
Does it rule out interstitial lung disease, absence of clubbing?
Uh, no,
No. No. Okay.
no.
Okay. Then
Pulse rate is 84 beats per minute, regular rhythm, normal volume and character. All peripheral pulses were felt bilaterally equally. No radiofemoral delay, no vessel wall thickening. Uh, Blood pressure was 140 over 80 millimeter of mercury in right upper arm in supine position. Respiratory rate 20 breaths per minute, regular abdominothoracic. Skin and hair normal. Nails, multiple longitudinal striations visible over nails of both
you mean
hands.
you means ridges.
Ridges. Yes, sir.
Yes. Okay.
Uh, Thyroid and breast normal.
The skin is
Uh,
normal.
yes,
Skin
sir.
skin is normal.
Yes, sir.
What do you expect to look for in the skin in this patient?
Uh, Erythema. No.
No, in the case of interstitial lung disease, what all things you suspect? You said he's on, if he's on amiodarone, he'll be having some pigmentation of his
Uh,
extremities.
Blue green
If he is
pigmentation.
having SLE, he'll have classical skin manifestations. If he is having systemic sclerosis, he will have that manifestation.
Okay, sir.
So, in a case of rheumatoid arthritis, you may get pyoderma gangrene also.
Yes, sir.
You may get rheumatoid nodules.
Mm.
So, skin is normal,
Yes, sir.
hair is normal. No diffuse alopecia, no alopecia areata to suggest autoimmune disease. Any markers here?
No, sir. No.
No, no markers here. Okay. Has he got lymph nodes?
No, sir. Lymph nodes are not palpable.
Which all conditions come with a lymph node enlargement and interstitial lung disease?
Sarcoidosis.
Sarcoidosis. SLE can have.
SLE.
SLE can have. Hmm? So that is
Yes,
one
sir.
possibility. Has he got any erythema nodosum, lupus pernio?
No, sir.
No.
There was no erythema nodosum, no
So
lupus pernio.
no clue to sarcoid in the general examination. He said he is a
Okay.
case of rheumatoid arthritis. You are not
Yes,
telling
sir.
about general examination anything to suggest arthritis in this case.
So there are no deformities that were visible in the patient.
No
Nebulizer
joint manifestations at all.
non-joint. Yes. No, sir.
Okay. Okay. Come to respiratory system.
Examination of respiratory system. Upper respiratory tract, nose, nostrils, and throat. Normal in examination. No sinus tenderness. Examination of chest on inspection. Trachea deviated to right. Shape of chest is normal. Supraclavicular hollowing is
Wait a
present.
minute. Before that, upper respiratory tract, which all conditions are associated with the upper respiratory problems?
Church syndrome.
What will you see in the upper respiratory tract?
Sinusitis will be there.
Sinusitis is seen in beginners.
Yes.
Granular metasonchitis.
Yes.
Which condition produces polyps in the nose? Churg-Strauss. Okay, Churg-Strauss. Yes. Which condition produces deformities of the ear and nose? Granular metasonchitis. Okay, saddle nose, cauliflower-like ears. Okay, carry on. And you may find lupus pernio in the nose. No. Okay. Okay, carry on. There is bilaterally symmetrical hollowing in the supraclavicular region.
Yes, sir.
Okay, what else?
No infraclavicular flattening, no drooping of shoulders, apex plate is not visible, respiratory movements bilaterally equivalent, all areas, respiratory rate 20 breaths per minute, regular rhythm, abdominal thoracic, no visible dilated veins, no visible scars or pulsations.
Which scar you are looking for in this particular patient?
Any thoracotomy scar?
Thoracotomy scar. Which condition produces thoracotomy?
Section of
Lobectomy or pneumonectomy? Lobectomy, pneumonectomy produces scar. Yes, it's a. In which condition you get a scar in the suprasternal notch? That will take you to mediastinoscopy. Suppose you got multiple small scars on the sides of the chest, what will you suspect? Thoracoscopy, and possibly biopsy done. Suppose you got supraclavicular scar, what will you suspect? Lymph nodes. Lymph node biopsy. That's right. So these are the things you specifically look for in a case of respiratory disease. Okay, right. Palpation.
Palpation. Trachea is deviated to the right. Chest expansion.
Is it grossly deviated or just deviated?
Just deviated.
Okay. Yes.
Chest expansion is 2 centimeter. Anteroposterior diameter.
Is it normal?
Yes, sir. 21 centimeter. Transverse diameter 29 centimeter.
No. Chest expansion 2 centimeters. Okay. It's decreased. 5. No. 2 to 5. More than 5 is normal. 2 is markedly diminished. Hemithorax measurements.
Anteroposterior and transverse. I didn't do.
No. And when you look at the chest movements, are they equal?
Yes, sir. They are equal.
Equal. So hemithorax expansion is same, equal on both sides. So both sides of lung shows decreased expansion. Right. Okay. Then.
Chest movements bilaterally equal in all areas. Vocal fremitus is bilaterally normal in all areas. On percussion, resonant notes heard over all areas. Auscultation.
Is there dullness in the lung bases? No.
No, sir.
No. Okay.
Was not appreciated.
Auscultation.
Normal vesicular breath sounds heard bilaterally in all areas with fine adventitious sounds of fine inspiratory crepitations heard bilaterally over mammary, inframammary, infraaxillary and infrascapular area. Vocal resonance bilaterally normal in all areas.
Okay.
Examination of central nervous system.
Nothing special, no, except for Parkinson's disease, nothing more. Cardiovascular
No.
system,
Cardiovascular system, aortic area, I could appreciate a loud systolic murmur, sir, in the sitting position.
differential
Uh,
diagnosis.
with the uh, aortic sclerosis, probably because of age.
Is this murmur connected to the carotids?
No, sir.
No. It is
No.
specifically localized to the aortic area. In this
Aortic
age
area.
group, such a localized murmur with preserved
Okay, sir.
A2 is suggestive of aortic sclerosis. Okay.
Okay, sir.
And the AP is not raised. Respiratory system, you
No,
already
sir.
said. GIT findings.
So GIT, one example, instead of the abdomen palpation, liver was palpable 5 centimeter below the right coastal margin,
Upper
in the
border.
clavicle
Upper
line.
border.
Uh, in the fifth, it was focused out on the fifth left intercostal space. Fifth intercostal margin.
Right.
Fifth right intercostal space. I'm
Okay.
sorry, sir.
Right. So it is there. Okay. Right. So
It was firm in
firm
consistency,
in
round ball,
consistency, tender or non-tender,
non-tender, sir.
surface
Smooth
is smooth,
surface and
non-pulsatile.
non-pulsatile.
Okay, so you have seen this patient. So what's your basic diagnosis here?
Uh, Possibility could be an acute infective
The
exasperation of
duration of the illness is
1 month.
1 month. So what
So,
infection comes like this?
mm, mm,
Tuberculosis can manifest
tuberculosis.
like this. Pneumocystis carinii pneumonia can manifest like this.
Yes, sir.
Histoplasma can manifest like this. So you have some differential diagnosis to offer, and you are
Yes,
proceeding
sir.
with the investigations.
Yes, sir.
So you have told the differential diagnosis for fever and cough. What is the
Yes, sir.
differential diagnosis for bilateral basal crackles?
Bilateral basal crackles could be part of pulmonary edema.
Pulmonary edema.
That,
Patients are usually very sick, always sitting up.
mm,
This patient was not that bad.
yes, sir.
Any other cause for bilateral basal crackles? Suppose it is with a lot of crackles and a lot of sputum, productive cough, what would have been?
Bronchitis.
Bronchitis. So this patient got
Yes.
specifically dry
Right.
cough with mid-inspiratory or end-inspiratory leathery crackles. So what
Yes, sir.
diagnosis you will suspect?
Uh, an interstitial lung disease.
Interstitial lung disease is a
Yes.
possibility. So let
Yes,
us
sir.
go to the. So you put 1, 3, 4 differential diagnosis for infection. Now you are coming
Yes, sir.
to interstitial lung disease. Can this be COPD?
COPD. Uh, if it were to be COPD, he would have in the respiratory system on inspection the chest shape and
You did not
with the
say
back.
about the tracheal tug. You didn't say about the intercostal indrawing. You didn't say about the accessory muscles. You didn't say about V's, squawks. What are squawks and squeaks? They are
No.
adventitious sounds.
Okay, sir.
Adventitious sounds heard at the end of inspiration, musical in nature,
Okay.
and suggestive of bronchiolitis.
Okay, sir.
Okay.
Okay, sir.
So, what investigations at this junction you want to plan?
Uh, uh, Hemogram with ESR.
Hemogram. Our eosinophil count is 50%. What all things comes to your mind?
Could be a eosinophilia associated with granulomatous polyangiitis.
Eosinophil associated with Church-Strauss
Or
syndrome, but they
yes,
present as asthma. Not like this. They present as asthma. Any other condition where can be eosinophilia, lung involvement, allergic bronchopulmonary aspergillosis.
bronchopulmonary aspergillosis.
Okay. You can
Okay,
have tropical pulmonary eosinophilia, again cough as a presentation.
okay, sir.
Would you like to do ESR on this patient?
Uh, yes,
Yes.
possibly.
And so you find it's 100. What do you say?
Um,
What is the expected ESR in rheumatoid disease? If it is active disease, you expect it to be very high. So also all autoimmune diseases, you expect it to be high. SLE. Okay. Any other investigation you want to do in this patient who is breathless? You want SpO2?
SpO2, yes,
Is
sir.
low. You want to do ABG?
Yes.
Okay. Oxygen saturation is low in this case. Suppose it is 60. Okay. You want to do X-ray test?
Yes, sir.
And what do you find? What do you expect?
Reticulonodular opacities.
Suppose you are getting only a bilateral symmetrical hilar lymph nodes. What possibility comes to your mind?
Sarcoidosis.
Sarcoidosis. Suppose it is only a multiple areas of calcification taking the shape of holy leaf. What do you suspect? Asbestosis. Suppose you are saying some lymph nodes calcified in the apex. What will you suspect? Silicosis. That's right. Silicosis. So you may get a reticulonodular shape. You may get streaks of fibrous tissue. Okay. Interstitial shadowing may be there. Okay. So it may be hazy all over. So wide varieties are possible. Okay. ECG may show RVH or it may be normal. So what are the investigations you want in this case?
To proceed with the high resolution CT, HRCT.
HRCT in this case showed bilateral ground glass appearance.
Yes, sir.
So what do you go to next?
Bronchoalveolar lavage.
So what type of disease you are dealing with? Ground glass appearance.
It's a chronic disease.
Chronic disease. Is it obstructive or restrictive?
Restrictive part.
So how will you confirm it is restrictive?
The pulmonary function test.
Yes. Which pulmonary function test you want to do?
No.
FE1 divided by FVC.
FVC.
Both will be low,
No.
but
No.
it will be less than 70%.
70.
So both will be proportionately diminished. So
Okay.
it will be less than 70. If you make the patient walk in the room, SpO2 may drop further. That may give clue. So how will you confirm that the capillary across the alveolar membrane oxygenation is not taking place? How will you recognize that?
Diffusion capacity.
Diffusion study has to be done. Okay.
Yes.
So here confirmed it is confirmed that it is a case of restrictive disease. How do you proceed further? You can go ahead with a. You said BAL. BAL. How does BAL help you?
Bronchoalveolar lavage.
If you find idiopathic type variety and BAL contain a lot of lymphocytes, these group of patients are responding very well to steroids.
Yes.
BAL may demonstrate malignant cells. So lymphangitis carcinomatous may be diagnosed. Pneumocystis carinii may be there and you may be able to make a diagnosis. Eosinophils in plenty may give clue to the eosinophilia associated situations, and sometimes you may get asbestos bodies. What is asbestos body and what does it mean to you? Yes, asbestos bodies indicates you are exposed to asbestos. That does not mean they are having asbestosis. To say asbestosis, they must have interstitial lung disease. So in this patient with interstitial lung disease, presence of asbestos bodies may be diagnostic. Okay, so one is BAL, bronchoalveolar lavage. So through bronchoscope, can you do anything else?
Biopsy.
Transbronchial biopsy may be done, which may give clue to the working diagnosis. So you may have a working diagnosis. So this particular patient's X-ray and the CT, everything showing that ground glass opacity is in the lower part and there is fibrosis. So what are the common causes of bilateral basal fibrosis?
Bilateral basal fibrosis, ILD, interstitial lung disease.
Due to what?
Due to the idiopathic pulmonary fibrosis.
Due to autoimmune diseases, 2 rheumatic diseases, 3 drug-induced diseases. 4. Asbestosis. Commonly,
Asbestosis.
all types of occupational hazards produces fibrous apex. Asbestosis exception, it comes in the periphery. Idiopathic also comes in the lower part.
Lower part.
Connective tissue diseases, rheumatic diseases produces fibrosis in the lower part. Exception is ankylosing spondylitis, which produces in the upper part. Okay, so
Okay,
once
sir.
you have done the biopsy, transbronchial biopsy, or you got a E-bus to the
Yes,
biopsy.
sir.
Open lung biopsy is not done these days. That may give a
Yes,
clue
sir.
to the etiology of the diagnosis. The
Diagnosis.
biopsy may give clue to diagnosis of Borrelia, borreliosis, silicosis, sarcoidosis.
Okay.
Okay, that may also give
Yes, sir.
clue regarding carcinoma in some cases where there is lymphangitis carcinomatosis like presentation. Biopsy may be
Okay, sir.
helpful. Okay, and
Yes, sir.
hypersensitivity pneumonias can also be diagnosed by biopsy. So these are 5 6 situations where biopsy will be helpful. The biopsy may not
Yes,
show anything specific for any disease. You have to conclude that possibly we are dealing with a idiopathic variety of
idiopathic.
pulmonary function, sorry, interstitial lung disease.
Yes,
But
sir.
in this particular patient, there is rheumatoid disease, there is history of methotrexate. So there are two causes for interstitial lung disease in this case. So that is a possibility. So when you look at the spectrum, one is a broad group idiopathic, which is diagnosed by ruling out other conditions. Rheumatologic disease second group, autoimmune diseases third group, eosinophilic lung disease fourth group, drug-induced diseases another group, bronchopulmonary aspergillosis a fifth group,
Okay.
sarcoidosis seventh group, different types of vasculitis eighth group.
Okay,
Then we
sir.
have got inhaled problems like extrinsic allergy, alveolitis, silica, asbestosis, so all associated. So these will be different groups of conditions producing interstitial lung disease in addition
Yes,
to
sir.
drugs as an important cause.
Okay, sir.
There is no history of amiodarone here, no history of nitrofurantoin, okay,
Yes, sir.
no history of busulfan, no history of bleomycin. So we don't
No,
have
sir.
any such drugs here. But the only history is there is a history of intake of methotrexate for 10 years. So that can explain this patient's illness.
Yes, sir.
Okay. So
Okay, sir.
so what are the interstitial lung diseases that can run in families? Rare things, rare genetic interstitial lung disease.
Familial pulmonary fibrosis.
Pardon?
Familial pulmonary fibrosis.
Neurofibromatosis, a rare
Yes.
condition where it can affect the lungs. Tuberous sclerosis, second group, which can produce Niemann-Pick's disease, can produce
Okay, sir.
the problem. Okay.
Okay, sir. Okay, sir.
So and then they got lymphangioliomatosis, conditions like that, which can also produce
Sure.
problems
Yes, sir.
in the families. They are rare,
Okay.
rare things. Okay.
Okay, sir.
So how are you going to treat this patient once you made diagnosis and you don't find any
Uh,
reason?
Immunosuppressants could be.
If there is a reason, you treat it. Withdraw the patient from
Okay,
the
sir.
environment, hypersensitivity, organic dust, treat the lymphangitis carcinoma, treat SLE, like that. When no
Okay, sir.
cause is found,
We can go for immunosuppressants and
like
cytotoxic,
like
like steroids.
steroids can be given, and then maintain on other
Uh,
steroid sparing anti
anti
inflammatory.
uh,
And you can may also
inflammatory.
try some anti-fibrotic drugs like
Yes, sir. Pirfenidone,
okay, perfenadone, very good.
ninten,
Ah,
and then nintedanib.
nintedanib is another one that may also be tried.
Yes, sir.
Oxygen administration in certain specific situations. If the patient is persistently in hypoxia, needs to be given continuously long-term domiciliary oxygen has to be
Oxygen
given.
therapy. Okay, sir.
Immunize the patient, stop smoking, give
Yes, sir.
supportive care, high protein
Yes, sir.
food. Treat the infection. This
Okay,
is
sir.
how these patients are taken care of.
Okay. Yes, sir.
Complications has to be expected. As this patient got flapping tremor,
No, sir. No flapping tremor.
no flapping tremor. So respiratory failure clinically is not recognizable. There's a
Yes, sir.
clue. There's edema, so maybe he was in failure. J is not raised. Right heart failure needs to be considered.
Yes, sir. Okay, sir.
So, is there a history of frothy urine?
No, sir. He did not give any history of frothing of urine.
If it was present, what would have been your thinking?
Uh, Nephrotic.
A nephrotic syndrome is possible
Yes,
due
sir.
to what?
Yes.
You have to extend a bit your imagination. Rheumatoid arthritis, many years, patient goes for amyloidosis, produces
Okay. Nephrotic
nephrotic
syndrome.
state.
And
Okay.
yes,
Suppose
sir.
this patient has got gum hyperplasia, what will you suspect?
Hyperplasia.
You have to think
Sorry.
about cyclosporine given
Okay,
for
sir.
immunomodulatory effect. Okay.
Okay. Yes, sir.
Similarly, if there is a purpura or Cushing-Watt features, you suspect this patient is on long-term
Steroids.
steroids. Steroids.
Okay.
Okay.
Yes, sir.
Now, if all the measures fail, you have to think about transplantation.
Okay, sir.
So this is how you proceed.
Okay, sir.
Okay.
Okay, sir.
So, Stephen, Stephen, Stephen has gone or not? Suppose it is an idiopathic variety, and how do you classify further?
Idiopathic pulmonary fibrosis, there is usual interstitial pneumonia, then non-specific interstitial pneumonia, uh, cryptogenic organizing pneumonia, then
Discomating, interstitial.
desquamating interstitial pneumonia,
Okay.
um, acute interstitial pneumonia, Hammond-Rich syndrome.
Okay. So there are different varieties of cryptogenic or idiopathic type of
Organized.
interstitial pneumonia, organizing pneumonia. Yes. Cryptogenic organized pneumonia. So wide varieties are there, and these are
Yes,
all
sir.
pathological diagnoses. Clinically,
Okay, sir.
all the 150 conditions will be grouped together to say interstitial lung disease. What's the
Lung disease.
pathology of this condition?
Uh, Interstitial lung disease, that's basically um, fibrosis.
Basically, where is the fibrosis? That's right. That's fibrosis. Where is the fibrosis?
In the lower lobes, mainly involves the basal segments. The small alveoli,
Yes, alveoli. So
smaller airways. Smaller airways are involved more
yes,
commonly.
basically the problem is in the alveolar walls
Yes,
inflamed
sir.
and vessels get occluded. Fibrosis follows. So although it's called as interstitial lung disease, basic problem is inflammation of the alveoli. Fibrosing
Okay.
alveolitis is the problem. Okay. Last comment by Naveen or Stephen.
Yes, sir.
Stephen. Stephen would like to add more points. Anything else? Naveen? Okay. I think basically general examination of this patient must be more elaborate to find out the etiology. History of pets at home, occupation,
Yes, sir.
bird fanciers lung,
Yes,
exposure to the inhalations, silica asbestos, organic dust, drugs, amiodarone, methotrexate, everything must come in the history of these patients. These are diagnosis by exclusion. In this case, there are clues: history of rheumatoid disease and methotrexate. Otherwise, each and every condition needs exclusion one by one. Okay.
Okay, sir.
Thank you.